Well, welcome to Chapter 54, Male Reproductive Disorders. So we'll first start talking about prostatitis. It's an inflammation of the prostate gland. So itis, we know, always means inflammation. So prostate in front of it, inflammation of the prostate. Now there is acute bacterial prostatitis and chronic prostatitis. With the acute prostatitis, the patient will need to be on oral or IV antibiotics, analgesics, and muscle relaxants. A 6 weeks course of antibiotics is prescribed for acute bacterial prostatitis. With the chronic prostatitis, they have a chronic pelvic pain syndrome, and they should be on antibiotics 6 to 12 weeks if it's indicated. Also, the chronic prostatitis, because of that chronic inflammation in the colon rectal area, they may be prone to constipation. So they want to be on stool softeners to prevent constipation because it can be very painful for them. And then there is also a symptomatic inflammatory prostatitis. Signs and symptoms would be pain, of course, problems voiding, and sexual dysfunction. And then diagnosis would be go by symptoms. Some lab tests might be drawn, check for infection, how to treat that infection, what antibiotics to be used, culturing the infection. Treatment would be analgesics and maybe some stress reduction, could be outpatient or inpatient antibiotics. And then let's talk about epididymitis. That's inflammation of the epididymis. And that may be caused by infections, trauma, or reflux of the urine from the urethra. Signs and symptoms: painful scrotal edema, nausea, vomiting, chills. It's treated with bed rest, ice packs, sitz baths, analgesics, anti-inflammatories, and scrotal support. And there is an instruction in the book about placing a rolled towel under the patient's thighs while in bed to elevate the scrotum and reduce the pain. That would be your scrotal support. Nursing care involves monitoring temperature, edema, and carrying out prescribed treatments and recording their effects. Also, if this is caused from an STI, we know that the partner should be treated as well. It's always important to remember that. Orchitis is inflammation of one or both testes. It may be related to trauma or infection. Mumps can cause orchitis. Now, in the last chapter, we talked about the ELISA lab test, and that is one. Mumps virus is one of the things involved in the ELISA. It's a myriad of lab tests. So it's important to know if the patient did have mumps, because this can be a problem for male. Pneumonia or tuberculosis. Signs and symptoms could be fever, tenderness, swelling of the affected testicle, and scrotal redness. It's treated with analgesics, antipyretics, bed rest, scrotal support, local heat. Nursing care would be pain management and assistance with ADLs. Benign prostatic hyperplasia. The signs and symptoms of that would be voiding issues. So they could have hesitancy, a weak urinary stream, straining, prolonged voiding, frequency, urgency, nocturia. So they have to urinate at night. They get up frequently during the night. Urge incontinence, voiding small amounts. I love the word micturition. They use that in this particular chapter. Post-micturation symptoms, so that's urination. Post-urination symptoms like dribbling, incomplete emptying of the bladder. Symptoms may be triggered by bladder irritants as well as some drugs. Alcohol, caffeine, and artificial sweeteners are some irritants. Medical diagnosis is made from symptoms and findings from a rectal exam. They might also do a catheterization for residual urine to see if they're emptying their bladder. Medical treatment, fluid restriction, 1,500 to 2,000 mLs a day, and especially do not drink 2 hours before bedtime. Avoid caffeine and alcohol because those are diuretics. And maybe some bladder training exercises. Those are similar to like the Kegels that a woman would do for urinary problems. There is a drug also that could be a medical treatment, and that's called Flomax, and that is a great drug to remember. Well, not for the test necessarily, but it's just easy to remember because the flow of urine is maximized. So Flomax, very good. I love it when medications tell you what they do. Makes it easier for us to remember, doesn't it? So surgical and invasive treatments, they might need a prostatectomy, but they do need to know that even if they did need surgery, like a prostatectomy or a TURP, that erectile dysfunction is unlikely. It's really important that as nurses, we allay that fear of erectile dysfunction because that is fearful. So transurethral resection of the prostate is TURP. So during the TURP, they insert an instrument in the urethra and destroy portions of the enlarged prostate. It's a pretty bloody surgery. They may have a big IV of fluids that, it's like a three-way catheter, and in the catheter, one of them is a port where they hook up fluids that pour into the bladder and irrigate the bladder out. And it can be pink at first, wouldn't be unusual. Pressure in the bladder is one cause of painful bladder spasms, so that might be something they experience. There's also a suprapubic prostatectomy performed through the bladder by a low abdominal incision. Convalescence is longer than with a transurethral prostatectomy, so they can either go through the urethra or make an incision just above the bladder area. All right. Complications would depend on the kind of surgery. Retrograde ejaculation may occur. This is not harmful to the patient, but does render him sterile in that particular case. That's a complication. Okay. Let's go to the next one. Let's talk about prostate cancer. So there is a lot of talk about prostatectomy in the nursing care of the patient with a prostatectomy. This could occur with the hyperplasia or with a cancer type of situation. So inspect urine dressings and wound drainage for excess bleeding. Maintain accurate I&O. There's a good patient teaching section on page 1067 for prostatic hyperplasia. And it talks about consult your physician or pharmacist about non-prescription drugs. Such as antihistamines can cause urinary retention. So just record the color of the urine and if there's any clots. Also, another intervention is potential for fluid volume deficit. So blood is common in the urine several days after a prostatectomy. However, the drainage should be light pink within 24 hours. Now, the catheters, so if you see dark blood, it may require pressure on the surgical area at the neck of the bladder. to apply pressure, the physician can signal hemorrhage and, the physician could apply pressure on the surgical area at the neck of the bladder. And they do that by injecting additional fluid into the balloon that anchors the catheter in place. So that's like a traction against the bladder. The catheter is pulled so that the balloon fits tightly against the neck of the bladder, and various forms of traction are used, including taping the catheter to the thigh. And this traction may be maintained for several hours or more and then released by the physician. So that's important to remember, that it is the physician that would do that, and that would be something you would expect the physician to do. Now, there is pain after prostatectomy and bladder spasms. So be sure you administer analgesics and any other kind of therapy that the doctor says to give. Erectile dysfunction is not common after surgical treatment for benign prostatic hyperplasia. So now we're on the prostate cancer. Early detection is by PSA, and that's one of the tests, the tumor marker for prostate cancer. Cancer of the prostate is found on postmortem exam in 30% of men over 50, and the incidence increases steadily with each decade to 100%. So if a man lives long enough, he's going to have prostate cancer. Isn't that interesting? So early detection is by PSA. Medical diagnosis can be based on the rectal exam, transrectal ultrasound, and PSA level. Medical treatment could be watchful waiting is what they call it. They just kind of keep an eye on the prostate. Radical prostatectomy includes removal of the prostate gland, the capsule, the seminal vesicles, sections of the vas deferens, and sometimes a portion of the bladder neck. The latter approach permits an autonomic nerve-sparing technique, which may preserve erectile function. The urinary incontinence that occurs in 10 to 15% of men who undergo radical prostatectomy subsides within 6 months to 85 to 90% of those affected. So that's important to know, isn't it? Now, a medication that could be given, it's in the second column there under prostate cancer growth influenced by hormones. So one medication that can be given is Nilandron, and we talked about that in the last chapter. So we want to watch for hepatotoxicity with that drug, and that could be with liver function tests. So nursing care, you want to, specific problems would be bladder spasms, erectile dysfunction, urinary incontinence, and body image disturbance associated with changes in reproductive system. So those few things are important. That's on page 1071. So I would really try to remember those specific problems that require intervention after prostate surgery. And also remember that a TERP does not affect function. Okay, let's go on to erectile dysfunction. It's the inability to produce and maintain an erection for sexual intercourse. It can be devastating for the man. Contributing factors can be vascular, like atherosclerosis, smoking, excessive alcohol consumption, inadequate exercise. Endocrine disorders could be something like diabetes and low testosterone. Autonomic neuropathy in patients with diabetes affects the ability of nerves to relax the smooth muscle. So it's important to manage diabetes, keep an eye on their blood sugar and their hemoglobin A1C, and watch their diet, of course, very important. Vascular surgery to clear clogged arteries is not usually recommended for people with diabetes because they often have complicating issues with nerves and cells, erectile tissue, blood vessels. But one thing that they could get is a penile implant. Let's see if I go to the next. So here's a picture, and it's on page 1072. I took one picture and put it in here, and that's C, because this is the most common that I've seen inflatable prostheses, because it can be done by the patient as needed. It may be recommended for a patient with failure to initiate due to nerve damage, maybe from a surgery or because they have diabetes, or failure to fill. That could be related to diabetes as well. Another problem is neurologic disorder. If communication between the spinal cord and the penis remains intact, the penis can still become erect. But in some spinal cord injuries, there is a disconnect in the innervation of the penis from the spinal cord, so they might need an inflatable prosthesis of some sort. Drugs can be used to reduce high blood pressure, antihypertensives, and they're most likely to interfere with erection, so that could be a problem. Maybe the medication needs to be adjusted and changed. There's some psychological factors that can go along with that. Interesting thing here, before we go on to the Peyronie disease, is the medical treatment for erectile dysfunction. Now, I want you to take a peek at the word papaverine. So, now this is painful to think about. Papaverine is a self-injection of intracavernosal medication for failure to initiate, fill, or store for psychogenic causes. It's injected with a small needle into the erectile chamber. Erection is achieved within 10 to 15 minutes and lasts 30 to 60 minutes. Also, they can have testosterone, that's oral replacement. And then the implants would be another option. So let's talk about Peyronie's disease. It's on page 1074. It's a hard, non-elastic, fibrous tissue or plaque that's built up under the skin of the penis of men between 45 and 70. Now, this plaque develops as a result of an injury that causes inflammation and scarring of the tunica surrounding the corpora cavernosa. So there's a picture there. It's like a crooked penis. Loss of elasticity of the tunica results in decreased ability to fill during an erection and failure to store because of low pressure on the veins against the covering of the erectile tissue. Priapism. So priapism is a prolonged unwanted penile erection that may be caused by low flow or high flow. It can be very painful. It can be caused from an injury to the penis or neoplasms of the brain or spinal cord. And I have seen this after spinal cord injuries. It's a prolonged erection, and it's secondary to the spinal cord injury. Drugs that can be responsible include phenothiazines, alpha-adrenergic blockers, some anticoagulants, alcohol abuse, cocaine, marijuana. It can be painful, and it constitutes an emergency situation. So failure to resolve this problem within 12 to 24 hours can result in ischemia, penile ischemia, gangrene, fibrosis, and erectile dysfunction. So the next thing I'd like to talk about is phimosis or paraphimosis. We talked a little bit about this in the last chapter, how important it is for cleanliness of a patient that is not circumcised. So what happens is they get a buildup of just like a discharge. It's very dirty because someone hasn't pulled back the covering of the penis, and it hasn't, the foreskin, and it hasn't been cleaned. So this is called phimosis. So it needs proper cleaning. And I have seen it where it's been so tight because it hasn't been pulled back that it was then unable to be pulled back. So it had to actually be cut, and that is not comfortable. It is not comfortable. So uncircumcised men need to retract the foreskin for cleaning as part of daily hygiene, as does the nurse. All right, let's talk a little bit about infertility. There's a lot on infertility. We talked about it in the female. Now we're going to talk about it from the male perspective. So couples who have unprotected intercourse over a 12-month period and have been unable to become pregnant. That is the definition of infertility. It could be caused from a reproductive problem in the male, and that would constitute some investigating the study, the sperm count. Studies need to be done of the female, which would constitute looking at her eggs and her anatomy to see if there's something there causing a problem. So some other causes and risk factors would be infection, cryptorchidism, which the testes are located in other than a dependent scrotal position, so that can cause infertility in the male. It really should be corrected in the first 18 months of life. After that, it can cause infertility. So that's important to remember, that it should be corrected in the first 18 months of life. Then there's testicular torsion. The spermatic cord twists, cutting off blood supply to a testicle. And this is usually seen in active adolescents. If you turn to page 1076, it talks about, and it even shows a picture of testicular torsion, and I have one in the next slide as well. It occurs when the spermatic cord twists, cutting off the blood supply to the testicle. And it's very common in adolescents because, like, they're jumping around, they're playing basketball, they're doing, they're running and jumping over hurdles, and their testicle could get twisted. If the testicle is deprived of blood for more than 4 hours, it can become necrotic and require removal. After testicular torsion is corrected, lowered sperm counts and infertility can follow. Another infertility problem is vasectomy. Well, yeah, vasectomy was done to render the male infertile. So that's surgical removal of tying of the vas deferens for sterilization purposes. It can be reversed, but it's usually considered to be permanent. And here's a picture of the testicular torsion, so you can see that twisting. That must be so painful, right? So the patient will complain of pain. And that can lead to lack of blood flow to the testicle and possibly rendering them impotent. All right, let's talk a little bit about penile cancer. It's relatively rare, almost exclusively in uncircumcised men. Risk factors: chronic irritation, poor hygiene, history of multiple sex partners, and sexually transmitted infections. Also, long-term tobacco use. It usually manifests as a dry wart-like painless growth on the penis that does not respond to antibiotic therapy. Remember, a wound that does not heal is always a bad sign. This is another instance. It can be removed surgically if treated in early stages. Advanced stages may ulcerate and involve the foreskin and penile shaft. Extensive resection or amputation, as well as resection of nearby lymph nodes, may be necessary. Okay, let's talk about, here's a picture of the vasectomy and how they snip the vas deferens. Usually, as I said, causes sterilization. But sometimes I know there's been instances where it grows back or even where they want it reconnected. And that could be possible. So let's talk about testicular cancer. Again, early detection is really important. Self-exam and early diagnosis. So usually the patient catches it first. And this exam, this self-exam, just like the woman checks her breasts, the man should check his testicles, done under a warm bath or shower when the patient is warm and the scrotum is relaxed. It's easier to feel any irregularities there. So men should be educated about the need for self-exam. And as I said, it should be done under warm bath or shower. That's really important to remember when he is warm and the scrotum is relaxed. And there is a picture on page 1078. Medical and surgical treatment, usually it depends on the type of cancer and the stage. You could have an orchiectomy, removal of the one testicle. So nursing care, they're going to be very anxious because they're threatened to their self-esteem and self-image. So as nurses, we have to be very sensitive to them and encourage them to talk. So listen actively. It's important to remember that. Also, they need to always, knowledge is power. So the more knowledgeable they are, how this doesn't really affect the way they look or even their ability to have children, it's important for them to talk about that. All right. Here's a picture of a testicular tumor. You can see it can be pretty small and it is hard to feel. That's why it's important to do it after a shower when the scrotum is relaxed and the patient is warm and the tissues are warm.